There are two forms of therapy, and we're comparing. At the end of the study, we want to compare if which one might be more effective, but also do some people do better with one type of therapy, and do some other people do better who have PTSD related to 9/11 do better with the other one. And one therapy is focused on the present and current problems and stressors and potential problem-solving strategies that the participant would come up with the help of the therapist. And the other one is more trauma-focused, focused on the 9/11 or World Trade Center experience and as a stressful and traumatic experience, and difficulties that people might still have related to that, and difficulties integrating the experience into one's life. And so just wanted to move to one side and briefly, the potential benefits. So in terms of the responders who live in this area, treatment is, for anybody having World Trade Center related PTSD, it's freely available and accessible and paid for anybody who does have. In terms of the survivors, there have traditionally been fewer resources. There are more resources now, and yet there are people who live a few hours away from this area or even further away, and it would be hard. So let's say they have PTSD symptoms and also depression, it'd be hard for them to come for weekly therapy, to come regularly. Other people are working, and so they have very busy schedules, and the only time they have time is in the evening, and most clinics are closed or weekend. Other people might have other barriers. For example, I know many cops, they don't want to be seen in the waiting area. Sometimes if they're retired, they don't mind as much, but there's still stigma, not just in the police force, but other communities. So and some people do better if they communicate with a therapist in writing without having to come face to face. For some people, it's easier to put their feelings and thoughts pen to paper, basically. And so for these reasons, these therapies, they're actually modified from supportive therapy and from cognitive behavioral therapy with an exposure component. And they've been found to be effective in person, and there's also some initial studies in other populations, not 9/11 responders, where people have benefited from these therapies. And so, so I just wanted to show you this is our flyer, and it's the same thing that any of you who are interested, and you can grab a flyer, and you can, if you know of other people or know of a community that might benefit, some other people that you get together with, you could grab a bunch of them. We made a lot of copies. But it's also, if you forget or you lose it, it's very easy if you do WTC online study and you put Mount Sinai on the internet, you're going to find it. And right now it still says, were you a rescue, recovery, or cleanup worker? We're actually requesting a change, a modification, so that we can also make it accessible to survivors. And you might have, for example, I can talk to you afterwards, in your program, some people who would benefit from this, but they actually live in Buffalo now.
Yes.
So when we open it up for survivors, that might be, for example. And so, so there's our website. And so this is for anyone to log in, therapists or potential individuals, participants, friends, anybody. You basically log in, and this is what you will see. It'll talk a little bit about PTSD, but most of you know, of course, what a PTSD is, but and what the online treatment consists of. And when you click on online treatment, you'll also be able to see some general information about the two forms of therapy, briefly, and how to proceed to the next step. And another tab is about confidentiality and privacy. It's all basically anybody who participates. First, so we do questionnaires periodically and at the beginning, but all that is done with an ID number, not with your name. And that's completely separate from the narratives that people write. And though the narratives that participants write, let's say if one of you were interested in participating and qualified, you would choose a name for yourself. Now, if your name is Janet and you want to say that your name, in terms of write about it, then the therapist in writing would address you as Dear Janet. But that's it. And And so it's, and also it's also behind the firewall, the protection, so that RedCap is approved by the IT security department at Mount Sinai. I worked very closely with them and made sure that we have a system that's secure.
Are you saying that they?
Sorry, I'm just recovering from a cold. Yep.
That there's anonymity then? I mean, can they not share their?
So there's not anonymity because our study staff excuse me, conducts an online, water would be great, but I don't know what everyone might, there's one here, maybe, there's one here. Sorry, I was afraid this might happen. There is, we do a telephone evaluation. Sorry, I might need to take a little break there.
I have a messenger too. Priyanka, maybe you could talk a little
Sorry,
bit
I'll be
about
right back.
It's okay.
And then, yeah, I'm sorry about that.
Okay. So at the Survivor program, which is again headquartered at Bellevue, but we have sites at Elmhurst and Gouverneur in Manhattan. For any folks who live outside of the 5 boroughs, we are creating a system. We've created a system where people can actually get care through the national program. We have a small external provider network that we're working to build up at this point, but in essence, very similar to the responder program. At the Survivor program, we provide all forms of mental health treatment that are known in the evidence base to help with symptom reduction, which means reduce the number of symptoms, help improve quality of life, help a person function better. So what we do offer is individual therapy, which is one-on-one counseling. We have psychiatrists on staff, and so those psychiatrists do some amount of supportive counseling, as well as provide medication management for those folks who would benefit from an addition of medication to manage their symptoms. And we have group psychotherapies. So at this point in time, we have skills groups that help people manage the symptoms that they are experiencing on an ongoing basis, whether it is PTSD symptoms, whether it is symptoms of largely anxiety, whether it is symptoms of just having difficulty managing emotion, and that impacting daily functioning. So we have groups that teach skills to manage PTSD symptoms, depression symptoms, anxiety symptoms. We also have groups that help folks dealing both with medical mental health issues and cancer, because we have a growing cohort of folks like the responder program who have people coming in with cancer, either newly diagnosed or the second time or the third time around. We also have groups like I think somebody mentioned earlier, like Adriana mentioned, DBT groups. We have a couple of providers who are able to provide Dbt Informed groups at this point in time. Folks who would really benefit from a Dbt Informed group would be those folks who have a hard time managing intense emotion. We're all capable of getting angry and rageful, getting very sad, getting impulsive. For folks who have consistent trouble managing those types of intense feelings, there are treatments that are well researched, that are available, that help manage how intense the symptoms get, how impulsive the person can get, through psychoeducation, through actual skills and doing homework and learning new behaviors to change the way we respond, we react, the way we behave in our life. So those kinds of folks who have a hard time regulating their internal thermostat, because of which they might experience things far more intensely, far more regularly, very intensely, and then act in those particular ways in life. They would sort of benefit from a group like that. So we have, at this time, 1 or 2 groups that are doing that kind of work. And then we have folks who may not be entirely ready to enter full-fledged mental health treatment, which can include weekly individual therapy for about 45 to 60 minutes with a psychologist, or a monthly session with a psychiatrist offering medication, counseling, and some supportive counseling. If a person is not ready for that kind of treatment, we have relaxation and sort of dealing with stress kind of workshops that are run by our social workers. And some of us supervise the social workers in doing those workshops. So what that does is it gives the person who's sort of thinking about treatment, not very sure they want mental health treatment, they're probably cagey about engaging in any kind of trauma-related work, or just are too overwhelmed and don't have the time or the energy to commit to treatment. These are great workshops because they're for 60 minutes. They're freely available to anyone who's part of the clinic, who can just literally walk in. You'd have to call, find out when the first workshop is, and you can pick up a flyer when you come in and keep attending these workshops. We have them in English and we have them in Spanish at this point in time. Because we also have a growing volume of folks coming in for care, we have both the social workers from the cancer team as well as the mental health team doing supportive counseling. Because, again, whether it's you're not ready to begin treatment, you have too many medical appointments, you don't want to add another one, or there is somewhat of a fear in engaging in full-fledged mental health treatment, supportive counseling enables somebody to get support either on a weekly basis or a sort of a bi-weekly basis, just to sort of keep them on track with what they need to do, keeping priorities up front, helping deal with psychosocial stressors. And a social worker at our program would be more than available to schedule a half an hour to 45-minute supportive counseling session. So these are the range of services we offer from our mental health team. The medical team, like the Responder program, has a range of ongoing monitoring and ongoing follow-ups that the specialty docs provide.
I wanted to ask, because you mentioned, and forgive me if I missed, if you had already talked about this, but I wondered about EMDR. Are they using that technique at the clinic?
At this point in time, it is provider specific and it is assessed on a case-by-case basis. A lot of, practically everyone that we deal with at our clinic has complex PTSD. What that simply means is that there's not been one big traumatic event. There have been maybe a couple. And when one layers on top of the other, it's not an additive effect, it is a multiplicative effect. So as a result of that, we've had two providers, including myself, that have made case-by-case decisions about when EMDR is indicated clinically. It does require a certain amount of commitment. EMDR is very physically activating. For those folks who are already physically ill, vulnerable, and medically compromised, it is quite an emotional and physical commitment. So we usually take a case-by-case decision, make a case-by-case decision about whether EMDR is indicated in its full protocol. But usually what I find myself and one or two other providers who are trained find ourselves doing is we do elements of EMDR, one of which is the Stabilization Protocol in EMDR, which is very simply put, and I'm oversimplifying, but very simply put, it helps someone just feel they're grounded enough that they can stand steady on their feet, emotionally and psychologically. Because a lot of what we do at our program, and my guess is across the Responder program as well, is when someone comes in for treatment, they may not be fully ready and able to engage in the length of trauma treatment that we could provide, which is sort of according to the model that the previous presenters sort of presented on. The first step is really for people to feel like they're stable, they can leave our clinic and not be overwhelmed by what they are experiencing. So EMDR is a nice adjunct to ongoing psychotherapy, potentially medication management. It's a little more of a complicated decision clinically to make in a general way. Like I said, because it physically activates people. But that is the work of EMDR in some essence.
And by going through that process, reaching some stabilization?
Again, I'm oversimplifying, but in essence, EMDR is hoping that when you undergo the entire protocol, you have enough of an inner physical and emotional strength that you can withstand the emotional and physical impact of the particular traumatic event. So for example, like the previous presenter said, having a car accident, driving on the road, that particular location in itself is a trigger, but it's a very physical trigger. So if someone who's, let's say, medically ill, not been in treatment, tends to get overwhelmed by the heart palpitations, very easily and very often we see people going up the ladder from what is a panicky feeling to a panic attack. In order for them to prevent having a panic attack or ride through the panic attack, for example, if they're on the road with the heart palpitations, EMDR, like any other therapy, would say, let's help the person feel calm enough that they can ride out these sensations, they can ride out these feelings. So we would never begin EMDR, we would never begin any kind of trauma-informed therapy if we feel the person is not emotionally equipped with stabilization skills, some of which, and actually critically, which involve mindfulness, breathing techniques, relaxation techniques, because it's only when the body is calm first that the mind literally can come online to do the work that we do in talk therapy. Because most talk therapy is top down. It expects the mind to sort of work with the body and be in connection for any change to happen. But in trauma-informed therapy, we are always trying to go bottom up, which is calm the body first so that the person feels steady and grounded enough, and then begin to reinforce some of these skills that they're learning to calm their body to do it the next time if they're home or once they leave the session.
Well, and safety and security is such an issue for these people, and feeling connected to the people that are providing the treatment. What do you have to say to someone that's searching for a clinician? I mean, what is it about that connection and feeling safe in that relationship?
I would think it's a great question for those of you folks who have been in treatment also, because a therapeutic connection that feels safe is felt in the space between two people. It's felt in how we make eye contact with you. It's felt right from the time you decide to call somebody or the clinic, for example, and the front desk person is friendly and is helpful. The therapeutic connection begins right there. If the front desk person, for example, has had a bad day and they're kind of grouchy, it could potentially impact what you think the therapeutic connection could be with the clinic and then your clinician. You haven't even gotten to the clinician. So the therapeutic relationship is a co-creation. It is created between myself and the person I'm going to be seeing. But what the clinician really does bring to the table is not just subject matter expertise around what helps and what modalities we are able to offer, but the ability to translate how trauma impacts somebody to that person. Because one of the biggest things across research, across clinical practice is if all else fails and you have a solid therapeutic relationship, you're going to see change. You're going to see some amount of healing in the person you're treating. So 1, it's a co-creation. 2, it begins way before you reach the clinician. 3, for someone searching for treatment, it's a good idea to be informed of what potentially is out there. But what is out there is like an ocean with a lot of gaps and dark holes. So the starting point is to actually just start reading. The internet is sort of like it's a double-edged sword. Sometimes you know too much and sometimes you know very little.
So there's no great starting point, but reaching a starting point, I think, is the beginning of just getting some care. So asking questions, coming to sort of forums like this. Within sort of a session, creating a safe therapeutic space, I think really lies in the nonverbal communication. If I'm making eye contact with you, if I seem interested and I'm not taking notes while I'm talking to you, these are things that patients tell us are so critically valuable to whether they will come back to us or not, or whether they decide we can help them or not. Simple things like eye contact, simple things like being able to answer questions. It's our job as providers to be able to answer questions to someone who's looking for care. Being able to offer a framework. Trauma impacts the person in a way where we need more structure than usual because trauma disrupts our sense of time, place, person. As a result of which, if someone's coming into our clinic and saying, I can't stop revisiting that particular day, our goal is not going to be to go into tell me what happened that day, but the goal is going to be to create safety in the here and now. So a big element of creating therapeutic alliance in the moment is to help the person feel okay in the moment.
I wanted to,
Sorry, no, please go ahead.
I just wanted to add, I apologize for my cough earlier. I just wanted to add something, and maybe you said this at the beginning, about trauma-focused therapy, that when the patient feels has reached that safe place to start facing some of the memories or what happened on that day or the aftermath, the idea is that in PTSD in general, what happens is the mixture of the traumatic memories coming often triggered or unannounced and overwhelming the person, and that alternating, or it could be grief also, alternating with avoidance. And the person, because they feel like they have no control over it, they try to push those thoughts out, and that compounds the problem because they come out of the blue again at another time or unexpectedly triggered by bad news on TV or anything. So the idea now, there's more and more understanding clinically and also from research that every time a memory comes up, if we're able to pay attention to the memory and tolerate the feelings that come up, like very gradually, that the memory can be relayed down in the mind and in the brain, slightly changed.
Yeah.
So that's sort of either it becomes less anxiety producing, or gradually it can be connected to other more positive or slightly more empowering perspectives. And so that's the idea, is like with trauma-focused therapy, it's not that we want to make the person suffer unnecessarily, but by avoiding and being very, very afraid of these thoughts and memories, the work of recovery doesn't happen. It's sort of like the person is sort of frozen in time and space at the time when the trauma happened. So by gradually being able to pay attention in the safety of the therapeutic relationship to the feelings and the thoughts and the emotions, that the memory and the experience can be reintegrated, and acceptance is a big part of trauma, and also reframing it and finding meaning and everything that we've been talking about, and being able to integrate the experience into one's life in a way that gives one hope and meaning, and not just loss.
The acceptance is so much a part of bereavement as well. So it's the acceptance, it's the integrating, it's making new meaning in your life, and being able to move forward. So I actually had that question, so you answered it before I could ask.
Oh, there you go. Yeah, you can ask, I'm sure you can ask more.
Did you want to finish
this?
Yes,
sure,
that would be
I'm happy,
great.
but this gentleman had a question for
Quick question.
Priyanka.
In my field work, sometimes I work with counselors and therapists, and you touched upon the quality of the relationship between, and both of y'all touched on it, between your client and yourself. Could you just touch on gift giving? Because that can really, that can bring up some slave to their entreaties to treat them in the way they want to be treated, maybe not deal with their existing issues. It's a real interesting challenge, and I'm sure you've encountered it.
Yeah.
I just wondered what your thoughts were.
It's a very good and difficult question because it's a multi-layered, potentially an issue, but not necessarily an issue. If I were to speak from the perspective of a program, we are guided by the ethics of clinical practice that don't encourage gift giving of any kind, because it sets up a potentially business-like, transactionary kind of relationship between a provider and a client. We are a federally funded program that have been instituted to provide care, ongoing monitoring, and clinical services, irrespective of whether we get anything in return or not. So at a programmatic level, we are governed by those ethical guidelines, which I think are very good to have for some of the reasons that you alluded to. If we take it sort of peel that layer back and go to an inner layer at a clinic level, we often get gifts from mystery gift givers who are grateful for the things that they have received from the service provider, whether it was just sitting with them and making sense of a 75-page form that they had to fill out for some kind of VCF application, or even just walking through a form or something very minor over the phone for about 10 or 15 minutes. The gratitude that comes through from our clients often comes through by them leaving gifts for us, bringing us chocolates or bringing us donuts or bringing a card. So if we sort of live and at that level, it can often call into question clinical ethics of, do you accept that as a gesture of human gratitude, or do you see it through the lens of a very black and white sort of policy of not accepting anything? And I can speak for myself because over the 5 years that I've been at the program, I've had folks come in and acknowledge that they want to give a gift for being grateful for what they received, and some people have just left it at the front desk. So it's not something that I would generalize, because we're dealing with we're in the culture of trauma-informed care. And a big portion of trauma-informed care is being able to make human connections with people who are suffering. And a part of acknowledging and honoring their suffering is to acknowledge how they are not only resilient in the face of their suffering, but choose to rework that story. Where if the story was, I felt alone and I felt helpless and I came to the clinic and you guys really helped me in doing something that really helped me or was hindering my life, it is honoring the fact that they're taking ownership of what's impacting them, the fact that they reached out for help, the fact that we were able to help and we had enough of a therapeutic alliance that they trusted in us and that we could trust them to do the work. And then we saw the results, and that we all bear witness to that new story. So from that perspective, I can speak for myself, is I often will have conversations with people who leave gifts, even if they leave it sort of with a note or a name, and I will call them and thank them. Of course, letting them know that ethically and clinically we do not expect them, or I do not desire a gift for what we have done for them, but we deeply appreciate it. So because there are many symbolic meanings to getting food, to getting chocolates, to getting things that are primarily nurturing. So allowing our members, our sort of patients, to be able to nurture us for what we give is part of reciprocal relationships. And so reciprocity is what helps healing. That is one of the sort of foundations of trauma-informed work. The reason Therapeutic Alliance works in trauma-informed care is because there is a very high level of attunement to what the person is experiencing in the moment. And that is the process of reciprocity. So it can often be a controversial issue, and we've had situations where the gift giving was not just that, but it was something more. And we've had to address it on a case-by-case basis. But I think in general, from a cultural standpoint, which is the other layer to gift giving, it's usually being deeply grateful for what they have received.
Do you see a difference in gift giving, let's say, Christmas time?
Yeah.
I mean, that's not, would that be considered an unethical thing to do that?
Again, I think if you live in the realm of sort of clinical practice and ethical guidelines, it definitely blurs the boundaries for providers to accept any kinds of gifts. But if you broaden the scope and look at it on a case-by-case basis, sometimes we do get chocolates, we get donuts, which we thank folks for giving it to us, but we share it with the team, or there is a little bit of a blurring of boundaries. Sometimes we do see more cards left for us during the holiday times, some gifts on occasion. But one of the things we preface with our clients is, because you're on a limited income, because funds are tight, please feel free to just drop in when you can and say thank you to the person who helped you. Those are sort of, I think, workarounds that sort of help us professionals stay in that ethical space of not accepting anything. But it's a complicated issue that I don't think we can generalize if we're the kind of clinic that really accepts people in different shades. Because, for example, during Christmas time, we'll have folks who come in who've, let's say, gone for a surgery, or were diagnosed with a cancer by one of our physicians, and we're just so grateful that our physician found out that this is what they have and they were able to do early intervention. We'll have them coming in, giving us cards, giving us food, because they're just so grateful that this didn't go unnoticed. So I don't know if that necessarily answers your question, but sometimes it is seasonal, and sometimes it's just based on how the person is sort of wanting to reciprocate.
We have about 5 more minutes, and I wanted to make sure that Dr. Feder, who's now recovered, is
Sorry.
able
So,
to.
I guess I took cough medicine this morning, but it started wearing off. But the Lozan just saved me. So no, just very briefly. So so anyone can log in. People who don't want to participate, people who know someone, clinicians, people who want to participate, and just to get information. And then at one point it says how under online treatment how to proceed to the next step. And so if you click on that, it'll say thank you for your interest in our online psychotherapy study. And before you continue, we want to let you know that research is completely voluntary. Your responses are strictly confidential, and you don't have to pay anything to participate. And if you're interested, potentially with no obligation of participating, do you want to complete this brief pre-screening? So if you click yes, then these are the 5 questions that will appear. And again, we'll change that to include the survivors as well in a couple of months. But because our therapists are, because of what I spoke about before in telemedicine, and we can't have a therapist who's not licensed in the state where the patient lives, then we have therapists who are licensed in New York, New Jersey, and Pennsylvania. So participants can live anywhere in these 3 states. So are you a resident of those states? Were you a rescue? Were you a responder? Are you currently receiving psychotherapy? Because if the person is receiving counseling already, they can't do 2 counseling forms of counseling at the same time. The medication, you can be on stable doses of medication before and during the study. So we just ask because we want to know. And are you still having symptoms related to your WTC experience? For example, upsetting memories and nightmares, becoming less connected with people around you, etc. And that's pretty much it. And your answers, basically, once you complete the pre-screening questionnaire, if you're not currently in therapy and you were a responder and you're living in one of those states, or in the near future if you're a survivor, then it takes you directly to the possibility of filling out an initial consent form for the study. So, and at any point in time, you can stop and call Hannah. Hannah Brinkman is the clinical research coordinator. She's wonderful working with me. Or you can email her if you don't feel comfortable, or the person intending to participate doesn't feel comfortable. And some people feel comfortable and they proceed and read the whole consent form, and at the end you type in your name, and that's the part that becomes confidential, because then it takes you to a questionnaire to start with, this time after you consented to at least being screened for the study, and your name never gets placed together with the answers to your questions. So those will be identified by a number. But we need to know how to contact you, because we need to establish a therapeutic relationship and assign you to a therapist. Yeah, question?
So are people who are getting therapy not allowed to participate because they'll contaminate the study?
What it is if you're already getting therapy, so there is no one way or one perspective or one way of working. So if you're working with two different therapists at the same time, then one therapist, you're working through a problem like this, and the other one. But also, if you're getting better during the course of the study and you're doing two therapies, the study that we won't know if it's the intervention that we provided that's helping, or is it the therapist that you're seeing at the same time. However, if you've been taking, for example, sertraline, one of the SSRI antidepressants, and you've been taking it for at least 3 months, or you've been taking it for a few years, and you've achieved a certain level after which it sort of helps you up to here, but you're still having persistent, significant PTSD symptoms, it's unlikely that the medication now, 2 years later, is all of a sudden going to start working. But we also, when we talk to people over the phone, before we assign them to work with a therapist, we ask them to please try not to change the dose or start a new medication during the study. And on periodic questionnaires online, which we do during the study, again, confidential with a number, no name, we ask, have you made any changes in the medications since the last time you filled out the questionnaire?
Yeah, I understand. I was just, as a private clinician, I really recommend a lot of my clients go to self-help groups. So if they're a recovering person, I'll say, continue with AA, it's really good, but
Sure.
4 o'clock in the morning, I'm not available, they're available. Sometimes people, when I give them my homework assignments, they may be writing, but this could really be, it's a shame, because sometimes
It is.
it's really helpful for someone to have
Sure.
something else.
So if we
Right.
know that, so first,
Right.
because this is a clinical trial and
Yeah.
it's a funded study, one of the goals of this study is to see if it works or not, if it helps 9/11 responders, and also if one of the two therapies works better than the other, or for different people. Once we've established that hopefully it works, it could be an additional, it could be adjunct. At this point, because the thing is, it's not self-help. There is a therapist, and the relationship, the connection with the therapist becomes quite deep, actually, because people pour their souls into the paper, and the therapist reads them, and the therapists are very empathic, and they're working with the client or the patient, so a relationship develops.
So it truly is a therapeutic relationship.
It is a
It's
therapeutic
not-
relationship in writing.
Okay.
It is absolutely.
A
Well, I
couple
think
quick
what-
questions.
I think.
Are you ending?
One quick question,
Okay.
because people are starting to come in.
Are you going to, both of these methods are in writing. Are you going to compare, or has it been compared already by some other study, about having an audio-visual interaction through, a telecommunication?
So online cognitive behavioral therapy has been compared to in-person cognitive behavioral therapy, and has been found to be similarly effective in some studies so far. In this particular study, we're only comparing the two modalities to each other, but that would be another way.
Yeah, because I'm wondering what's the difference in writing back and forth
Well,
versus
there-
interacting back and forth?
Sure, no, that's a very good question. There is a tradition or there is a modality which is also even narrative writing prescribed by an in-person therapist. The advantage of this is also that the responses are extemporaneous. So a person could be coming home from work at 8 p.m. when the therapist is not available, let's say, and could decide to write at 8:30 or 8:45. sends confidentially the text, and the therapist, again, when they have time the next day, sets aside some time to read it and respond. So it's a different mode, and takes advantage of the kind of like self-reflection that a person does. It's like diary writing. So it's a different form of therapy. It should be compared to telemedicine, sort of also. That I'm not sure if it's been compared that way. Yeah.
Well, one of the things that I feel very strongly about is thinking about more creatively about how we can provide services for people that are geographically challenged, which we saw after 9/11. There were families around the country and in 90 countries. And so we started very early on teleconference groups. Before it was really a concept.
Now it's a thing.
But I thought,
Mhm.
there's
ahead of the
got to be
time.
some way where we can connect these people.
Absolutely.
And we found also early on that parents didn't want to talk in front of their children, children didn't want to talk in front of their parents, firefighters didn't want to talk with civilians, same with police or military at the Pentagon. So we really had to group like with like and provide that opportunity for families to, or members of a family, to meet with people that had that shared experience where they felt safe and comfortable, and most of them doing it right from their comfort of their own home and not having to travel. And that's a big issue too with World Trade Center survivors and responders going into New York, for instance. But the other
Some
thing
people won't
is to
even
think
come.
in terms of, is there a group modality for PTSD? Because with the common occurrence of acts of mass violence, school shootings, I mean, you can't go to a church, a synagogue, a concert, and on anymore. In these communities, you know, there's not enough therapists in the world to deal with the amount of trauma that's actually occurring right now. So I think we have to think, you know, as professionals about how can we deliver these services
Flexibly.
and more flexibly and to meet the needs of the people that need the service. So I think this is terrific, and I hope
Thank
that
you.
we can help promote that.
No,
and-
thank you for giving me the opportunity to talk a little bit about the study here. And again, there's a bunch of flyers that I'm going to leave here and also at the table when you sign out. And if you know of anybody who might benefit from this, you can also take a look at your website and get more information.
Great.
So,
And we'll send something out to
Great.
the people in those particular states.
Great.
Yeah.
Thank you.
So I can work with you on that. Well, thanks both of you for, I mean, not just once, but twice, sitting down and talking to the audience. And I hope you'll give them a round of applause.
Thank you very much.
Are they coming? Okay, we're going to get started now. And we're talking about treatment modalities for the World Trade Center program, both responder and survivor treatment modalities. And we talked quite a bit, I guess it was the second session, about the World Trade Center health program. But I think what I'd really like to do is go a little more in depth about some of the research and some of the treatment modalities, and then give you more time to be able to ask more specific questions. So, do we want to start with you, Adriana, to talk about your research? Yeah.
So, I don't know if some of you have already heard me talk about this, besides this morning where I talked about this online psychotherapy study. So, and then I have flyers that we can distribute afterwards. So, NIOSH is funding this psychotherapy study that compares two online therapy studies, and I'll explain what it is. Right now, it's for rescue and recovery workers, but we're opening it up in about a couple of months to survivors as well. And it's for those workers or later survivors as well who are still experiencing PTSD symptoms, along with other depression, adjustment symptoms. There's still anybody who's still haunted by the 9/11 experience, World Trade Center recovery experience. And what it is, and I just brought a few slides just to walk through a couple of things, to walk everybody. But basically, it's a narrative writing therapy, where after an online and over-the-phone evaluation, participants or individuals who qualify and are interested in participating, we ask them to set aside 45 minutes twice a week to set aside some quiet time to write for 45 minutes. And they get assigned an individual therapist, and participants and their therapist communicate in writing via a secure portal that's located at Mount Sinai. But I don't know if any of you are familiar with Redcat. But basically, it's anybody who has a computer at home and has access to the internet, you basically type into a Microsoft 45 minutes, and then you copy and paste and submit your text to the therapist. And you get instructions, you get a response. It's as if you were talking to a therapist in person, but it's a reflection, and you get instructions for how to conduct a reflection, a little bit like what we did before with previous presenters. But and then you get feedback from the therapist and in writing and further instruction. And it's a total of 11 writing exercises over approximately twice a week. So it's about 5 or 6 weeks. And there are two forms of therapy, and we're comparing. At the end of the study, we want to compare if which one might be more effective, but also do some people do better with one type of therapy, and do some other people do better who have PTSD related to Emdr and do better with the other one. And one therapy is focused on the present and current problems and stressors and potential problem-solving strategies that the participant would come up with the help of the therapist. And the other one is more trauma-focused, focused on the 9/11 or World Trade Center experience and as a stressful or traumatic experience, and difficulties that people might still have related to that, difficulties integrating the experience into one's life. And so, just wanted to move to one side briefly, the potential benefits. So, in terms of the responders who live in this area, treatment is, for anybody having World Trade Center related PTSD, it's really available and accessible and paid for anybody who does have it. In terms of the survivors, there have traditionally been fewer resources. There are more resources now, and yet there are people who live a few hours away from this area or even further away, and it would be hard. So let's say they have PTSD symptoms and also depression. It would be hard for them to come for weekly therapy, to come regularly. Other people are working, and so they have very busy schedules, and the only time they have time is in the evening, and most clinics are closed or weekend. Other people might have other barriers. For example, I know many cops, they don't want to be seen in the waiting area. Sometimes if they're retired, they don't mind as much, but there's still stigma, not just in the police force, but other communities. So and some people do better if they communicate with a therapist in writing without having to come face to face. For some people, it's easier to put their feelings and thoughts pen to paper. And so for these reasons, these therapies, they're actually modified from supportive therapy and from cognitive behavioral therapy with an exposure component. And they've been found to be effective in person, and there's also some initial studies in other populations, not 9/11 responders, where people have benefited from these therapies. And so, so I just wanted to show you this is our flyer, and it's the same thing that any of you who are interested, and you can grab a flyer. You can, if you know of other people or know of a community that might benefit, some other people that you get together with, you can grab a bunch of them. We made a lot of copies. But it's also, if you forget or you lose it, it's very easy if you do WTC online study and you put Mount Sinai on the internet, you're going to find it. And right now it still says where you rescue, recovery, or cleanup worker. We're actually requesting a change, a modification, so that we can also make it accessible to survivors. And you might have, for example, I can talk to you afterwards in your program, some people who would benefit from this, but actually live in Buffalo now. So when we open it up for survivors, that might be that, for example. And so there's our website. And so this is for anyone to log in, therapists or potential individuals, participants, friends, anybody. You basically log in, and this is what you will see. It'll talk a little bit about PTSD, or most of you know what PTSD is, but and what the online treatment consists of. And when you click on online treatment, you'll also be able to see some general information about the two forms of therapy briefly, and how to proceed to the next step. And another tab is about confidentiality and privacy. It's all basically anybody who participates phase. First, so we do questionnaires periodically and at the beginning, but all that is done with an ID number, not with your name. And that's completely separate from the narratives that people write. And though the narratives that participants write, let's say if one of you are interested in participating and qualify, you would choose a name for yourself. Now, if your name is Janet and you want to say that your name, in terms of write about it, then the therapist in writing will address you as Dear Janet. But that's it. And so it's, and also it's also behind the firewall, the protection. So the red cap is approved by the IT security department at Mount Sinai. I work very closely with them to make sure that we have a system that's secure.
Are you saying that they,
I'm sorry, I'm just recovering from a cold. Yep.
that there's anonymity then? I mean, can they not share your?
So there's not anonymity because our study staff conducts an online water secret. This was sealed here. Maybe this one here. Sorry, I was afraid this might happen. There is, we do a telephone evaluation. I might need to take over.
I have a more suggestion. Priyanka, maybe you should probably-
Sorry, I'll be right back.
Okay. Sure.
And then, yeah, sorry. Okay. So at the Survivor Program, which is again headquartered in Bellevue, but we have sites across the year. For any folks who live outside of the 5 boroughs, we are creating a system. We've created a system where people can actually get care through a national program. We have a small external provider network that we're working to build up at this point. But in essence, very similar to the responder program, at the survivor program, we provide all forms of mental health treatment that are known in the evidence base to help with symptom reduction, which means reduce the number of symptoms, help improve quality of life, help a person function better. So what we do offer is individual therapy, which is one-on-one counseling. We have psychiatrists on staff, and so those psychiatrists do some amount of supportive counseling, as well as provide medication management for those folks who would benefit from, in addition of medication, to manage their symptoms. And we have group psychotherapies. So at this point in time, we have skills groups that help people manage the symptoms that they are experiencing on an ongoing basis, whether it is Ptsd symptoms, whether it is symptoms of largely anxiety, whether it is symptoms of just having difficulty managing emotion, and that impacting daily functioning. So we have groups that teach skills to manage Ptsd symptoms, depression symptoms, anxiety symptoms. We also have groups that help folks dealing both with medical mental health issues and cancer, because we have a growing cohort of folks like the responder program who have people coming in with cancer, either newly diagnosed or the second time or the third time around. We also have groups, like I think somebody mentioned earlier, like Adriana mentioned, Dbt groups. We have a couple of providers who are able to provide Dbt Informed Groups at this point in time. Folks who would really benefit from a Dbt Informed Group would be those folks who have a hard time managing intense emotion. We're all capable of getting angry and rageful, getting very sad, getting impulsive. For folks who have consistent trouble managing those types of intense feelings, there are treatments that are well researched, that are available, that help manage how intense the symptoms get, how impulsive the person can get through psychoeducation, through actual skills and doing homework and doing
learning new behaviors to change the way we respond, we react, the way we behave sort of in our life. So those kinds of folks who have a hard time regulating their internal thermostat, because of which they might experience things far more intensely, far more regularly, very intensely, and then act in those particular ways in life, they would sort of benefit from a group like that. So we have, at this time, 1 or 2 groups that are doing that kind of work. And then we have folks who may not be entirely ready to enter full-fledged mental health treatment, which can include weekly individual therapy for about 45 to 60 minutes with a psychologist, or a monthly session with a psychiatrist offering medication, counseling, and some supportive counseling. If a person is not ready for that kind of treatment, we have relaxation and sort of dealing with stress kind of workshops that are run by our social workers. And some of us supervise the social workers in doing those workshops. So what that does is it gives the person who's sort of thinking about treatment, not really sure they want mental health treatment, they're probably cagey about engaging in any kind of trauma-related work, or just are too overwhelmed and don't have the time or the energy to commit to treatment. These are great workshops because they're for 60 minutes. They're freely available to anyone who's part of the clinic, who can just literally walk in. You have to call, find out when the first workshop is, and you can pick up a flyer when you come in and keep attending these workshops. We have them in English and we have them in Spanish at this point in time. Because we also have a growing volume of folks coming in for care, we have both the social workers from the cancer team as well as the mental health team doing supportive counseling. Because, again, whether it's you're not ready to begin treatment, you have too many medical appointments, you don't want to add another one, or there is somewhat of a fear in engaging in full-fledged mental health treatment, supportive counseling enables somebody to get support either on a weekly basis or a sort of a bi-weekly basis, just to sort of keep them on track with what they need to do, keeping priorities up front, helping deal with psychosocial stressors. And a social worker at our program would be more than available to schedule a half an hour to 45-minute supportive counseling session. So these are the range of services we offer from our mental health team. The medical team, like the responder program, has a range of ongoing monitoring and ongoing follow-ups that the specialty office provide.
I wanted to ask, because you mentioned, forgive me if I missed, if you had already talked about this, but I wondered about EMDR. Are they using that technique in the clinic?
At this point in time, it is provider specific and it is assessed on a case-by-case basis. A lot of, practically everyone that we deal with at our clinic has complex PTSD. What that simply means is that there's not been one big traumatic event. There have been maybe a couple. And when one layers on top of the other, it's not an additive effect, it is a multiplicative effect. So as a result of that, we've had 2 providers, including myself, that have made case-by-case decisions about when EMDR is indicated clinically. It does require a certain amount of commitment. EMDR is very physically activating. For those folks who are already physically ill, vulnerable, and medically compromised, it is quite an emotional and physical commitment. So we usually take a case-by-case decision, make a case-by-case decision about whether EMDR is indicated in its full protocol. But usually what I find myself and one of the other providers who are trained find ourselves doing is we do elements of EMDR, one of which is the Stabilization Protocol EMDR, which is very simply put, and I'm oversimplifying, but very simply put, it helps someone just feel they're grounded enough that they can stand steady on their feet, emotionally and psychologically. Because a lot of what we do at our program, and my guess is
across the responder program as well, is when someone comes in for treatment, they may not be fully ready and able to engage in the length of trauma treatment that we could provide, which is sort of according to the model that the previous presenter sort of presented on. The first step is really for people to feel like they're stable, they can leave our clinic and not be overwhelmed by what they're experiencing. So EMDR is a nice adjunct to ongoing psychotherapy, potentially medication management. It's a little more of a complicated decision clinically to make in a general way, like I said, because it physically activates people. But that is the work of EMDR in some sense.
By going through that process, reaching some stabilization.
Again, I'm oversimplifying, but in essence, EMDR is hoping that when you undergo the entire protocol, you have enough of an inner physical and emotional strength that you can withstand the emotional and physical impact of the particular traumatic event. So for example, like the previous presenter said, having a car accident, driving on the road, that particular location in itself is a trigger, but it's a very physical trigger. So if someone who's, let's say, medically ill, not been in treatment, tends to get overwhelmed by the heart palpitations, very easily and very often we see people going up the ladder from what is a panicky feeling to a panic attack. In order for them to prevent having a panic attack or ride through the panic attack, for example, if they're on the road with the heart palpitations, EMDR, like any other therapy, would say, let's help the first person feel calm enough that they can ride out these sensations, they can ride out these feelings. So we would never begin EMDR, we would never begin any kind of trauma-informed therapy if we feel the person is not emotionally equipped with stabilization skills, some of which, and actually critically, which involve mindfulness, breathing techniques, relaxation techniques. Because it's only when the body is calm, first, that the mind literally can come online to do the work that we do in talk therapy. Because most talk therapy is top down. It expects the mind to sort of work with the body and be in connection for any change to happen. But in trauma-informed therapy, we're always trying to go bottom up, which is calm the body first so that the person feels steady and grounded enough, and then begin to reinforce some of these skills that they're learning to calm their body to do it the next time they're home or once they leave the session.
Well, safety and security is such an issue for these people, and feeling connected to the people that are providing the treatment. What do you have to say to someone that's searching for a clinician? I mean, what is it about that connection, feeling safe in that relationship?
In fact, I would think it's a great question for those of you folks who have been in treatment also, because a therapeutic connection that feels safe is felt in the space between two people. It's felt in how we make eye contact with you. It's felt right from the time you decide to call somebody or the clinic, for example, and the front desk person is friendly and is helpful. The therapeutic connection begins right there. If the front desk person, for example, has had a bad day and they're kind of grouchy, it could potentially impact what you think the therapeutic connection could be with the clinic and then your clinician. You haven't even gotten to the clinician. So the therapeutic relationship is a co-creation. It is created between myself and the person I'm going to be seeing. But what the clinician really does bring to the table is not just subject matter expertise around what helps and what modalities we are able to offer, but the ability to translate how trauma impacts somebody to that person. Because one of the biggest things across research, across clinical practice is if all else fails and you have a solid therapeutic relationship, you're going to see change. You're going to see some amount of healing in the
person you're treating. So one, it's a co-creation. Two, it begins way before you reach the clinician. Three, for someone searching for treatment, it's a good idea to be informed of what potentially is out there. But what is out there is like an ocean with a lot of gaps and dark holes. So the starting point is to actually just start reading. The internet is sort of like a, it's the double-edged sword. Sometimes you know too much and sometimes you know very little. So there's no great starting point, but reaching a starting point, I think, is the beginning of just getting some care. So asking questions, coming to sort of forums like this. Within sort of a session, creating a safe therapeutic space, I think really lies in the nonverbal communication. If I'm making eye contact with you, if I seem interested and I'm not taking notes while I'm talking to you, these are things that patients tell us are so critically valuable to whether they will come back to us or not, or whether they decide we can help them or not. Simple things like eye contact, simple things like being able to answer questions. It's our job as providers to be able to answer questions to someone who's looking for care. Being able to offer a framework. Trauma impacts the person in a way where we need more structure than usual because trauma disrupts our sense of time, place, person. As a result of which, if someone's coming into our clinic and saying, I can't stop revisiting that particular day, our goal is not going to be to go into tell me what happened that day, but the goal is going to be to create safety in the here and now. So a big element of creating therapeutic alliance in the moment is to help the person feel okay in the moment.
I wanted to,
Sorry.
I just wanted to add, I apologize for my cough earlier. I just wanted to add something, and maybe you said this at the beginning about trauma-focused therapy, that when the person or the patient feels has reached that safe place to start facing some of the memories or what happened on that day or the aftermath, the idea is that in Ptsd in general, what happens is the picture of the traumatic memories coming often triggered or unannounced and overwhelming the person, and that alternating, or it could be grief also, alternating with avoidance. And the person, because they feel like they have no control of it, they try to push those thoughts out, and that compounds the problem because they come out of the blue again at a time or unexpectedly triggered by that TV or anything. So the idea now, there's more and more understanding clinically and also from research that every time a memory comes up, if we're able to pay attention to the memory and tolerate the feelings that come up, like very gradually, that the memory can be relayed down in the mind and the brain, slightly changed. So that's either it becomes less anxiety producing, or gradually it can be connected to other more positive or slightly more empowering perspectives. And so that's the idea, is like with trauma-focused therapy, it's not that we want to make the person suffer unnecessarily, but by avoiding and avoiding and avoiding and being very, very afraid of these thoughts and memories, the work of recovery doesn't happen. It's sort of like the person is sort of frozen in time and space at the time when the trauma happened. So by gradually being able to pay attention in the safety of the therapeutic relationship to the feelings and the thoughts and emotions, that the memory and the experience can be reintegrated, and acceptance is a big part of trauma, and also reframing it and finding meaning in everything that we've been talking about, and being able to integrate the experience into one's life in a way that gives one hope and meaning.
Well, and the acceptance is so much part of the bereavement as well. So it's the acceptance, it's the integrating, making them meaning in your life, and being able to move forward. So I actually have that
Oh, there you go. Yeah, you can ask, I'm sure you can ask more. Sure, I'm happy, but this gentleman had a question for.
Quick question. In my people work, sometimes I work with counselors and therapists. And you touched upon the quality of the relationship between, and both of you all touched on it, between your client and yourselves. Could you just touch on gift giving? Because that can bring up some interesting oppositional perspectives, because on the one hand, to reject it, the person, if they're very fragile, could kind of take that as a personal rejection. On the other hand, they can see it, maybe they don't see it, but they're kind of hoping that you're kind of enslaved to their entreaties to treat them in the way they want to be treated, maybe not deal with their existing issues. So it's a real interesting challenge, and I'm sure you've encountered it. I just wondered what your thoughts were.
It's a very good and difficult question because it's a multi-layered, potentially an issue, but not necessarily an issue. If I were to speak from the perspective of a program, we are guided by the ethics of clinical practice that don't encourage gift giving of any kind, because it sets up a potentially business-like, transactionally kind of relationship between a provider and a client. We are a federally funded program that has been instituted to provide care, ongoing monitoring, and clinical services, irrespective of whether we get anything in return or not. So at a programmatic level, we are governed by those ethical guidelines, which I think are very good to have for some of the reasons that you alluded to. If we take it one, sort of peel that layer back and go to an inner layer at a clinic level, we often get gifts from mystery gift givers who are grateful for the things that they have received from the service provider, whether it was just sitting with them and making sense of a 75-page form that they had to fill out for some kind of VCF application, or even just walking through a form or something very minor over the phone for about 10 or 15 minutes. The gratitude that comes through from our clients often comes through by them leaving gifts for us, bringing us chocolates or bringing us donuts or bringing a card. So if we sort of live at that level, it can often call into question clinical ethics of, do you accept that as a gesture of human gratitude, or do you see it through the lens of a very black and white sort of policy of not accepting anything? And I can speak for myself because over the 5 years that I've been at the program, I've had folks come in and acknowledge that they want to give a gift for being grateful for what they received, and some people have just left it at the front desk. So it's not something that I would generalize, because we're dealing with we're in the culture of trauma-informed care. And a big portion of trauma-informed care is being able to make human connections with people who are suffering. And a part of acknowledging and honoring their suffering is to acknowledge how they are not only resilient in the face of their suffering, but choose to rework that story. Where if the story was, I felt alone and I felt helpless and I came to the clinic and you guys really helped me in doing something that really helped me or was hindering me in my life. It is honoring the fact that they're taking ownership of what's impacting them, the fact that they reached out for help, the fact that we were able to help and we had enough of a therapeutic alliance that they trusted in us and that we could trust them to do the work. And then we saw the results, and then we all bear witness to that new story. So from that perspective, I can speak for myself, is I often will have conversations with people who leave gifts, even if they leave it sort of with a note or a name, and I will call them and thank them. Of course, letting them know that ethically and clinically we do not expect them, or I do not desire a gift for what we have done for them, but we deeply appreciate it. So if, because there are many symbolic meanings to getting food, to getting chocolates, to getting things that are primarily nurturing. So allowing our members, our sort of patients, to be able to nurture us for what we give is part of reciprocal relationships. And so reciprocity is what helps healing. That is one of the sort of foundations of trauma-informed work. The reason Therapeutic Alliance works in trauma-informed care is because there is a very high level of attunement to what the person is experiencing in the moment. And that is the process of reciprocity. So it can often be a controversial issue, and we've had situations where the gift giving was not just that, but it was something more. And we've had to address it on a case-by-case basis. But I think in general, from a cultural standpoint, which is the other layer to gift giving, it's usually being deeply grateful for what we have received.
Do you see a difference in gift giving, let's say, Christmas time?
Yeah.
That's not, would that be considered an unethical thing for you to accept?
Again, I think if you live in the realm of sort of clinical practice and ethical guidelines, it definitely blurs the boundaries for providers to accept any kinds of gifts. But if you broaden the scope and look at it on a case-by-case basis, sometimes we don't get chocolates, we get donuts, which we thank folks for giving it to us, but we share it with the team, or there is a little bit of a blurring of boundaries. Sometimes we do see more cards left for us during the holiday times, some gifts on occasion, but one of the things we preface with our clients is because you're on a limited income, because funds are tight, please feel free to just drop in when you can and say thank you to the person who helped you. Those are sort of, I think, workarounds that sort of help us professionals stay in that ethical space of not accepting anything. But it's a complicated issue that I don't think we can generalize if we're the kind of clinic that really accepts people in different shades. Because, for example, during Christmas time, we have folks who come in, let's say, gone for a surgery, or were diagnosed with a cancer by one of our physicians, and we're just so grateful that our physician found out that this is what they had and they were able to do early intervention. We'll have them coming in, giving us cards, giving us food, because they're just so grateful that this didn't go unnoticed. So I don't know if that necessarily answers your question, but sometimes it is seasonal and sometimes it's just based on how the person is sort of wanting to reciprocate.
We have about 5 more minutes, and I wanted to make sure that Dr. Feder is now recovered.
Sorry. So I guess I took cough medicine this morning, but it started wearing off. But the wasn't just saved me. So no, just very briefly. So so anyone can log in. People who don't want to participate, people who know someone, clinicians, people who want to participate, and just to get information. And then at one point it says how under online treatment how to proceed to the next step. And so if you click on that, it'll say thank you for your interest in our online psychotherapy study. And before you continue, we want to let you know that research is completely voluntary. Your responses are strictly confidential, and you don't have to pay anything to participate. And if you're interested, potentially with no obligation of participating, do you want to complete this brief pre-screening? So if you click yes, then these are the 5 questions that will appear. And again, we'll change that to include the survivors as well in a couple of months. But because our therapists are, because of what I spoke about before in telemedicine, and we can't have a therapist who's not licensed in the state where the patient lives, then we have therapists who are licensed in New York, New Jersey, and Pennsylvania. So participants can live anywhere in these 3 states. So are you a resident of those states? Were you a rescue? Were you a responder? Are you currently receiving psychotherapy because the person is receiving counseling already? They can't be on stable doses of medication before and during the study. So we just ask because we want to know. And are you still having symptoms related to your WTC experience? For example, upsetting memories of nightmares, becoming less connected with people around you, etc. And that's pretty much it. And your answers, basically, once you complete the pre-screening questionnaire, if you're not currently in therapy and you were a responder and you're living in one of those states or in the near future if you're a survivor, then it takes you directly to the possibility of filling out an initial consent form for the study. So, and at any point in time, you can stop and call Hannah. Hannah Brinkman is the clinical research coordinator. She's wonderful, working with me. Or you can email her if you don't feel comfortable, or the person intending to participate doesn't feel comfortable. And some people feel comfortable when they proceed and read the whole consent form, and at the end you type in your name. And that's the part that becomes confidential, because then it takes you to a questionnaire to start with, this time after you've consented to at least being screened for the study, and your name never gets placed together with the answers to your questions. So those will be identified by a number. But we need to know how to contact you, because we need to establish a therapeutic relationship and a scientific therapist. Yeah.
So are people who are in therapy not allowed to participate or contaminate the study?
What it is if you're already getting therapy, so there is no one way or one perspective or one way of working. So if you're working with two different therapists at the same time, then one therapist, you're working through a problem like this, and the other one. But also, if you're getting better during the course of the study and you're doing two therapies, the study that we won't know if it's the intervention that we provided that's helping, or is it the therapist that you're seeing at the same time. However, if you've been taking, for example, sertraline, one of the SSRI antidepressants, and you've been taking it for at least 3 months, or you've been taking it for a few years, and you've achieved a certain level after which it sort of pokes you up to here, but you're still having persistent significant PTSD symptoms, it's unlikely that the medication now, 2 years later, is all of a sudden going to start working. But we also, when we talk to people over the phone, before we assign them to a therapist, to work with a therapist, we ask them to please try not to change the dose or start a new medication during the study. And on periodic questionnaires online, which we do during the study, again, confidential with a number, no name, we ask, have you made any changes in the medications since the last time you filled out a questionnaire?
Yeah, I understand. I was just, as a private clinician, I really recommend a lot of my clients go to self-help groups, so if they're recovering first time, say, continue with AA, and still good, 2 o'clock in the morning, I'm not available. Sometimes people, when I give them a homework assignment, maybe writing, but this would really be a shame, because sometimes
It is.
it's really helpful for someone to have something else.
So if we know that, so first, because this is a clinical trial,
Yeah.
and it's a funded study, one of the goals of this study is to see if it works or not, or if it helps 9/11 responders, and also if one of the two therapies works better than the other, or for different people. Once we've established that it works, it could be an additional, it could be adjunct. At this point, because the thing is, it's not self-help. There is a therapist, and the relationship, the connection with the therapist becomes quite deep, actually. Because people pour their souls into the paper, and the therapist reads them, and the therapists are very empathic and are working with the client, with the patient. So a relationship develops.
So it truly is a therapeutic relationship.
It is a therapeutic relationship in writing.
Okay.
It is absolutely.
A couple of quick questions. Are you in these?
One quick question.
Okay.
because People are starting.
Are you going to, both of these methods are in writing. Are you going to compare, or has it been compared already with by some other study, about having an audio-visual interaction through, telecommunication?
So online cognitive behavioral therapy has been compared to in-person cognitive behavioral therapy. It has been found to be similarly effective in some studies so far. In this particular study, we're only comparing the two modalities to each each other. But that would be another way.
Yeah, because I'm wondering if what's the difference in writing back and forth
Well,
versus interacting back and forth?
Sure, no, that's a very good question. There is a tradition or there is a modality which is also even narrative writing prescribed by an in-person therapist. The advantage of this is also that the responses are extemporaneous. So a person could be coming home from work at 8 p.m. when the therapist is not available, let's say, and could decide to write at 8:30 or 8:45, sends confidentially the text, and the therapist, again, when they have time the next day, sets aside some time to read it and respond. So it's a different mode and takes advantage of the kind of like self-reflection that a person does, like diary writing. So it's a different form of therapy. It should be compared to telemedicine or also that. I'm not sure if it can compare that way. Yeah.
Well, one of the things that I feel very strongly about is thinking about more creatively about how we can provide services for people that are geographically challenged, which we saw after 9/11. There were families around the country and in 90 countries. And so we started very early on teleconference groups. Before it was really a concept.
That was the thing.
But I thought there's
Ahead of
got to be
time.
some way where we can connect these two thoughts. And we found also early on that parents didn't want to talk in front of their children, children didn't want to talk in front of their parents, firefighters didn't want to talk with civilians, same with police or military at the Pentagon. So we really had to group one by one and provide that opportunity for families to, or members of a family, to meet with people that have that shared experience where they felt safe and comfortable and most them doing it right from their comfort of their own home and not having to travel. And that's a big issue too with World Trade Center survivors and responders going into New York, for instance. But the other thing is to think in terms of, is there a group modality for PTSD? Because with the common occurrence of acts of mass violence, school shootings, I mean, you can't go to a church, a synagogue, a concert, and on anymore. In these communities, there's not enough therapists in the world to deal with the amount of trauma that's actually occurring right now. So I think we have to think, as professionals about how can we deliver these services more flexibly and to meet the needs of the people that need the service. So I think this is terrific, and I hope that we can help promote that.
Well, thank you for giving me the opportunity to talk a little bit about the study here. And again, there's a bunch of flyers that I'm going to leave here and also at the table when you sign out. And if you know of anybody who may benefit from this, you can also take a look at the website and get more information.
Right, and we'll send something down to the people on those particular studies. So I can work with them. Well, thank both of you for, I mean, not just once, but twice, sitting down and talking to the audience. And I hope you give them Well, we're going to end with a mindfulness exercise right now, but I want to just say a big thank you to everyone that made today's
So this is your take home, or take out as well. I'm not really totally
Great,
sure.
you just phone in, put your order in, get your skills done, and you go home.
I'm not quite sure what mindfulness is, because it's become a word that means all kinds of things. You have a question?
No, I had a comment.
It was?
Well, since it looks like Chinese food, and usually people say Chinese food doesn't last too long, is your resiliency going to last?
That's why you have to order out another night.
So we were joking about this, but self-care, regardless of whether you're a professional, and it looks like there might be more professionals now. All right, good. So anyway, we were talking about this. So you know when they get on the plane, they go, you know, in the event of loss of cabin pressure, you know, put on your mask first. And that's kind of what we're talking about here is for all of us, caregivers, we're not caregivers, we're taking care of ourselves. Probably also caregivers to others. Put your mask on first. Take care of yourself.
And so probably one of the biggest pieces of mindfulness is learning to stay in the present, stay with it, relish it, take that moment. And most of us live, if you live in the Northeast, which is in this area, your life is more rushed than relaxed. Every moment is rushed. You're rushing to get out, rushing to the exit, rushing to the bus. And those moments of mindfulness, they're only in therapy. We better be in therapy every day. So we want to really be in the present. It's one of the nicest ways to be mindfulness. That mindfulness is to stay in the present moment. You don't have to stare at a raisin all day. That's not needed. But something where you really are focused on mindfulness. And not so caught up in it that we're thinking of everything else in therapy and applying and all that. But true mindfulness means that's it in that moment. And sometimes it's just stopping and noticing where we are in that moment. Sitting, standing, but not ticking off the next client, or I have 9 minutes of mindfulness. You can't do that. It has to be sort of without boundaries.
Everybody knows what SUD is? So for those who don't, it's a great way to measure when your distress level is going up. Give yourself a baseline. You know, 0 is domestic repulses. Did that come that you put a mirror under your nose? Or 10, you need to call 911 because you need to be hospitalized. Your anxiety is tipping you over the edge. So we use it with clients to determine where is the level of distress. Certainly when you come in to a session, if you're at a 5 and you go home at a 7, they should probably be looking for somebody else to work with. Right? Because at the very least, they shouldn't get worse after they were with, or at least when they left the meet. And that's it for you. So when you're driving down Morris Ave like me towards the ShopRite, and your son was 1 when you left campus because you're done with your classes, and then it's 7, I need to do something. Right? So it's always a good gauge for all of us. Yeah, so one of the things, when you're distressed, you breathe in through your mouth, right? And when you tell people take a deep breath, you often try to breathe through their mouth. So you tell them to touch their tongue to the roof of their mouth. First of all, that touches the